Okay, almost. All right, so it is 8:05. So we're going to get started with the lecture, and anyone else who joins us, I'll let them in. Grace, can you keep an eye on the waiting room? Just so,
Yes, I can.
great, great. But let me see if I can, I'm going to make you, let's see if I can do that because I was just made the co-host. No, I don't have that power. Okay, because it looks like I would be the only one to let people in. So let's see. Okay, we've got some people waiting in the waiting room. So let's admit. Okay. Looks like people are still coming in. But I'm going to pull up my lecture here, share my screen. There we go. All right. Oops. All right. There are people still joining us. So I'm going to give, maybe a couple more moments. I don't want to miss anybody. Can you guys see my screen okay?
Yes.
Thank you, Grace. Okay, so we're going to be talking about comprehensive diabetic foot examinations. Dr. Cuffey talked yesterday. His objectives were, oops, there's some action going on in the chat. Oh, great, perfect. His objectives 1, 2, and 3 really discussed a little bit of pathology, discussion of diabetes, but my objective 4 is going to be an assessment techniques for diabetic foot wounds. Now, I want all of the nurses and all of the healthcare professionals in the Zoom to focus on the fact that we're going to be talking about practical skills. It would have been better for us to do this kind of in a face-to-face setting so we could practice, but I understand, the timing and things of that nature. So it's going to be just easier to talk about it. But I did put in a lot of videos in the lecture, and I will share the lecture with Dr. Mitchell so she's able to provide it to you all because there's some important information here in terms of your assessment of your diabetics. My students on the call will see a lot of the techniques I will talk about that I've already taught them. I've recently taught them, so they will see some things that are going to be repetitious. So these are the things we're going to do this morning. We're going to discuss the skills in conducting a comprehensive foot exam in our diabetic patients. We're going to talk about inspection, palpation. There's even a little bit of auscultation here when we get into the Doppler and evaluation of vascular and neurological status. We're going to learn a little bit about using the tools to various assessments like monofilaments. I'm even going to discuss a little bit about something called the Ipswich test, which is similar to the monofilament test in that it assesses fine touch, but it's only if you don't have a monofilament. So in those locations where you don't have one, or you don't purchase one, or you just need like a quick and dirty neurological assessment, Ipswich works just as well. And Doppler ultrasound for neuropathy. And that's what I said. We were Doppler ultrasound for vascular assessment. So we're going to watch a video. We're going to listen to some sounds on the Doppler and so that you can really kind of really understand what it's supposed to sound like.
Who's going to feel the pressure. That's when the big boys have stood up at various points of time, especially in a case whenever India has gone out to do that.
Can you please mute yourselves? I'm not sure who that is.
Number one.
Perfect, thank you. And then we're going to talk a little bit about the principles of wound care. Wound care is in essence, it's complex, but once you really understand it, it is simple because we have to follow the steps. We have to make sure, is this incorrect? Let's fix that. Is this incorrect? Let's fix that. Because if you don't, then the wound is not going to heal. I'm also going to show you a little bit of a video of debridement, offloading video, and just one type of dressing techniques that's appropriate for wounds. And finally, we're going to talk about a little bit of multidisciplinary approach and collaboration. And this is going to be the in part of my talk. And I'm going to really let Dr. Londonio, who on Thursday, really discuss this part because it's more of a community collaboration exercise. But all of the healthcare professionals on the call would definitely be able to benefit. And finally, I'm going to highlight some effective communication and teamwork among the healthcare professionals for comprehensive diabetic care. All right, let's get down to it. So we're going to discuss first how to conduct a comprehensive foot exam. So first, we're going to focus on inspection. So when we're looking at the legs, so this is the normal dorsal aspect of the foot. This is a dark-skinned individual. You can tell that they have a little bit of tan. This might be common a lot in some of your population who wear flip-flops or open-toed shoes, where around the distal toes, you're going to see lighter skinned, and that's mostly only because of the tanning. But this is honestly absolutely normal skin, and this is what we're looking for: normal skin, normal nails on the dorsal aspect of the foot. And then we're going to assess the bottom part of the foot. Now, this is one of the patients that I saw. I saw her on Sunday. So this is obviously an abnormal bottom of the foot. We have discoloration and thick skin around the heel. We've got discoloration and thick skin in the arch, even around the medial aspect of the, like right under the first toe here. And then we have a wound right at the tip of the first toe. So this is absolutely 100% abnormal. And we're going to talk about what these things are, and especially this wound at the top. This is a type of pressure ulcer. On examination, this toe was completely turned down, so she walked on it and caused a lot of pressure there, which developed into a wound. This is another example of a abnormal callus on the medial aspect of the first toe. This patient's, when you're seeing this, these have to come down. I would not recommend my nursing staff, if you've never debrided a callus or anything along those lines, I wouldn't recommend it at first, but if you spend some time with Dr. Johnson in the South Beach office or Dr. Mitchell, they may be able to assist you kind of first times. But this is more of a practice for, folks skilled with the use of the blade in podiatry. And so then we're gonna inspect the front of the legs. This is also an abnormal appearance of the leg. And, my students will look at this and will recognize, the darkness of the skin, the hemosiderin deposition around the anterior aspect. And hopefully if I have some third years on the call, they'll be able to identify already the diagnosis for this patient. But this is a patient with chronic venous insufficiency, and we get this kind of very dark staining of the skin because of the pooled blood inside. We don't have a wound yet. We just have discoloration. So again, this is, making sure we are inspecting all aspects of the legs and the foot. We're making note of it. And even it's even sometimes important to take photos. If your clinic has the capability to take photos and put them in the chart, that's even great because it helps with continuity of care so that you can see what their legs look like on this day. All the way until the next time that you see them to be able to assess them more appropriately and for any treatment plan that needs to be offered. This is just another example of we're taking a look at the back of the leg, and this is something that is sometimes missed. So we want to make sure that our patients, if you're seeing a diabetic patient very first time, or even, every 3 to 6 months, we don't just want to look at the tops of their foot, take off your shoes, or even if they're wearing pants or anything like that, just to look at their feet. No, we want to look at the entire knee and below to assess the entire leg, the entire back of the leg, the entire bottom of the foot, the entire top of the foot, because sometimes there can be things that can be missed under clothing. So make sure that you have those patients wear at those visits shorts or skirts that can be easily moved upward. We can, of course, place a towel on their lap for modesty. But we want to make sure that we're looking, because if we don't, there may be something that we need to find. Okay. And then finally, we're going to take a look at in between the toes. So I typically will explain to my students that there's something called maceration, which is just wetness that happens in between the toes. In lighter skin individuals, it looks more like this appearance where it's kind of a whitish appearance. In darker skinned individuals, it's more of kind of a purplish, pinkish appearance, but it does not look like quote unquote normal. It does not appear a normal skin type or skin texture. But the question when we're asking about maceration is it pathologic? Is it an infection? Are we considering athlete's foot, bacterial infection, or is it simply that it is just wet? That the patient did not dry in between the toes very well after their shower, or do they sweat a lot in between their toes? Especially in those folks that work in jobs where they have to wear closed-toe shoes and they're very active. So that requires a different thought process than actually something that is red and swollen and itchy, and so there is a difference between pathologic maceration and just wetness that we can address with foot hygiene, with just foot hygiene. Are there any questions before I move on? Just want to make sure, you guys can stop me at any time, ask me questions. I want to make this as interactive as possible. But so far we're pretty in this simple area of our talk, but again, just let me know. And finally, we're going to take a look at the toes. So this is a photo of nail fungus. The way that I typically look at nail fungus, I mean, I've been doing this a long time, so I can typically see the difference between nail fungus or other nail pathologies. But the only real way to absolutely know if someone has nail fungus is to do some pathology on that, to take a piece of the nail and send it to pathology to determine if there is. However, nail fungus has a typical appearance of being thickened, dystrophic, as in, ridging that occurs in the nail, being discolored, and in darker individuals, that discoloration is going to veer more on those dark browns, dark yellows, grays, and it's going to make that nail very friable, very crumbly, and very difficult to cut because it's thick. So a normal nail cutter that you would purchase from a pharmacy is not able to cut those nails because they're way too thick. It will even cause the nails to ingrow and cause the patient pain. This is not going to be a discussion on treatments for, onychomycosis or what to do with that, or nail fungus, or, anything like that. I mean, if you guys have questions about at the end, and if you really want to know, we can, do a little bit of a cursory conversation on that. But this is more about inspecting the nails to be able to document in the chart, and if they are painful for the patient, to refer them to the podiatrist for debridement, for cutting of the nails, or for treatment of the nails in terms of topical or oral medications. All right, so we're going to move on to inspection and palpation of vascular exam. So first, we're going to just inspect the hair growth. So when we're looking at the vascular examination, first thing is inspection. So we're looking at the foot, and if they grow those fine hairs on the legs, and especially those fine hairs that occurs on the right behind the toes, then we know that their circulation is working all the way distally to the tips. The tiny, tiny capillaries that will feed those hairs are patent and open and are growing. So then we know something's happening. There's pulses happening, at least there's collaterals happening, because there's filling those small capillaries in order for the hair to grow. So I'm gonna stop and show you guys another screen so I can show you these videos here. And give me 1 second, let me just make sure I know where I'm going. I do. Here we go. All right, here we go. All right, you guys see my screen okay? Hopefully, yes.
Yes.
Great, thank you, Grace. All right, so I did some research, and I was trying to find kind of the simple kind of video tutorials that talked a little bit about, how to assess vasculature, how to assess neurological examination. And I came across this diabetic foot course by Motivation Australia. And I really enjoyed it because they use a lot of dark-skinned individuals, which are similar to the patient population in the Bahamas. So it's very similar to those guys. So let me make sure. Let's see. Can you hear? Can you guys hear?
No.
Okay. Oof. Share sound, Lord. Hold on. That's what I always forget to do. Share sound. All right, let's try this again.
Start the procedure by ensuring correct hand hygiene practices have been followed before seeing a new client.
You guys see the screen and hear the screen?
There are two main pulses in each foot. These can be used to assess blood flow to the feet. To confirm that a person has good blood flow, you need to be able to easily find both of these pulses on each foot. When testing for pulses, always use your first and middle finger, not your thumb. Your thumb has its own pulse and can confuse the results. Starting at the big toe, work your way to the center and top of the foot. This is where you should feel the top pulse. Start at the big toe and work your way back to the ankle bone. Feel behind the ankle bone. With light pressure, feel for the inside ankle pulse. Record your findings and repeat the process for the other foot.
So I liked this video because it was very simple. You don't need to know what these pulses are. You don't need to know what their names are.
Record your findings to monitor the person's vascular status and assess the risk of lower limb complications. Explain your findings from the test to the person. If you are unable to palpate any pulse, it suggests there may be reduced blood flow to the feet. Do a Doppler assessment and other vascular examinations to further investigate.
All right. So you don't need to know what those pulses are, although my students will be able to tell you that the dorsal foot pulse is called the dorsalis pedis, and the pulse behind the medial malleolus is called the posterior tibialis. And you're using your second and third finger to assess the pulses. Again, never the thumb, because the thumb has its own pulse in there. There is a way to kind of grade pulses 0 to 4, but I typically tell my students or anyone who is trying to determine, just tell me yes or no. Can you feel it or can you don't? Because for someone who's been doing, this for a long time, like myself, I can tell the difference between a 1 or a 2. Students or folks that are new to this process, maybe not, but all we want to know is, can you feel the pulses or can you not? Any questions about that so far? All right. So the next vascular assessment we're going to take a look at, and again, I really like these videos because they're fast and they're quick, and they're going to give you some information really easily, without, with a concentration on not quite your knowledge, but even if you know absolutely nothing, you'll be able to view, excuse me, and understand these tests. So the next one we're going to take a look at is looking at the capillary filling time.
Start the procedure by ensuring correct hand hygiene practices have been followed before seeing a new client. This test helps to assess perfusion and blood flow reaching the toes and feet. Start by pressing firmly with your finger to the tip of the big toe and then let go.
Did you guys catch that? So I always try to explain to my students that there is a difference between capillary fill time on lighter skinned individuals and darker skinned individuals. It is much more obvious to see that blanching, that kind of almost to white that happens in Caucasian individuals. But darker skinned individuals, it's less of that blanching white and more of a lesser pink that occurs. So I'm just going to play this one more time, and I wish I can slow this down, because I want you to see when he presses right on that toe, it just goes just a tiny less pink, and then immediately goes back to, his normal color.
Of the big toe and then let go. Count how many seconds for the toe to return to normal color. Note whether the refill takes less or more than 3 seconds.
You see that? Gosh,
If longer than 3 seconds, it may indicate reduced perfusion to the toe. Repeat this test on both feet and record your findings.
So we're looking for, with capillary filling time, we're looking for a reperfusion, or basically a return to normal color less than 3 seconds. Anything over 3 seconds, we're not happy about. 3 to 5 is sometimes, because of the disparity between kind of, your seconds and my seconds, people will kind of take as normal, but definitely anything over 5 seconds, people will say absolutely not, that's an abnormal finding. Capillary filling time is done on 1 through 10 toes, and we want to make sure that the perfusion is normal across 1 through 10. And finally, we will take a look at our Doppler examination of the toes, and
Counts of blood cells. This
is an examination of the pedal pulses, but only if you have a Doppler. I think that Dr. Mitchell told me that there are Dopplers available in the clinics. If they're not very expensive. I mean, they're not, I wouldn't say that they're kind of medical grade, but there are Dopplers that, you could definitely purchase that can be used to just assess the sounds of the arteries. And if it doesn't sound right, and we're going to actually listen to them today, then you can refer those patients to vascular, or to even one of the local podiatrists to kind of verify your findings. And if needed, we'll send them to vascular for a check. So let's take a look. And I really like this video. So let's take a look.
A Doppler ultrasound is a device which uses sound waves amplified through a microphone to bounce off blood cells. This allows you to listen to the quality of blood flow of the artery. These are the parts of a Doppler that you will need to know. Start the process by ensuring correct hand hygiene practices have been followed before seeing a new client. Using your pointing and middle finger, locate the pulse you are looking to find with the Doppler. Watch our video on how to find the pulse on a foot if you are unsure how to do this. Apply a small amount of ultrasound gel to the top of the foot. Turn on the Doppler, increase the volume, and gently search for the pulse. Place the probe on a 45-degree angle against the line of blood flow. This will help amplify the sound. There are 3 types of pulses you can hear through the Doppler. Each sound indicates the quality of blood flow reaching the foot. This sound is a monophasic pulse. This is 1 beat per pulse and is abnormal. This may suggest reduced blood flow with signs of peripheral arterial disease. Biphasic pulse. You will hear 2 beats per pulse. This is considered normal. Triphasic. You will hear a triple beat per pulse. This may indicate pulses are bounding and elastic. This can be normal or indicate high blood pressure. If you find this sound, it is likely you are listening to a vein rather than an artery. Relocate the Doppler and look for a pulse. Repeat these steps for the ankle pulse.
What kind of pulse sound is that? Anybody?
Wipe away the Doppler gel using a paper towel. Record your findings to monitor the person's vascular status and assess their risk of lower limb complications.
So like I said, I really enjoyed this video. The sounds on auscultating the pulses are great in this video. It really differentiates between monophasic, which is abnormal, biphasic, which is normal, and triphasic, which is either normal or evidence of non-traceable arteries or hypertension. There's action going on in the chat. Let's see. Oh, yes, it is biphasic, 100% biphasic. Absolutely. You're hearing those 2 sounds that happen. So thank you very much, Miss Allen and Miss Knowles. Right. So we're going to go back to our lecture. Okay. So we've taken a look, we've inspected for hair growth, we've listened, we've palpated for our pulses, we've done our capsule tests, we've even done a little bit of advanced Dopplering assessment of our pulses. And now we're going to talk a little bit about edema. So there is 2 types of edema. And we're not going to go through the whys and the hows, but I will typically explain to my patients that, when the veins don't work, then we have some changes that can occur in the legs. On the left, we have a photo of pitting edema. There are grades to pitting edema, but honestly, it's just good to know, is it pitting or is there not? the depth of the pitting can be graded, but for us and for our purposes and for simplicity, it's does it pit or does it not? To the right, we have a photo of more Barani edema, and it's just non-pitting edema. It's edema that there's complete disappearance of the skin lines, and the skin and the leg cannot be compressed or pitted. But it is obviously edema, and that's typically associated with lymphedema or the other types of vascular compromise. Again, we're not going to have, a huge conversation about the whys and the hows, the etiology of venous disease. We just want to know, for us, can we determine it, that this is not right, that this patient sitting in front of me has legs that are swollen, either pitting or not. And if that's the case, then a vascular assessment has to be made. The patient needs to be referred to vascular doctor or for vascular studies to be able to determine what's going on with this patient. All right, so now let's talk about inspection and palpation for neurological status. So like I said in the beginning, I want this talk to be able to teach anybody to do a comprehensive vascular exam, from my undergrad all the way to my MD DPM, who's been doing this 12 years, who doesn't remember how to do these exams, because we want to be able to have reach. We want to be able to teach and expand on the knowledge of everyone across the island so that they can do a comprehensive exam and have some information about every single diabetic patient that walks into the door. So I've made the neurological exam very simple, very simple. So the first one I'm going to show you is called the Ipswich test. And I am going to, again, show you some videos. And we are on the same Motivation Australia. So let's take a look. Oh, wait a minute. You know what I didn't do? I did not share with sound. So let's make sure we do that. Yes, we did. Okay. Let me know if there's an issue with sound. Hopefully.
Before seeing a new client, ensure correct hand hygiene and infection control processes have been followed. Diabetes can commonly lead to reduced sensation in the feet and legs. This increases the risk of injury, foot wound development, and wound worsening. Early screening to assess if a person has loss of protective sensation helps to intervene and provide appropriate education, protection, and support. Explaining the test to the person helps teach them about diabetes and reduces stress. Ask the person to nod and say out loud, "Yes," every time they feel you touch. Ask the person to close their eyes before starting the test. Use the diagram to see the order to touch the 6 toes, 1 through to 6. Touch the tip of these toes with your pointing finger. Touch lightly once and only for 1 second. Wait a few seconds between each toe to give the person time to respond. If available, you can also use a monofilament to undertake this test.
So we're going to talk a little bit more about the monofilament in a moment.
Record your findings. Based on the test, if the person was able to feel, apply a tick to the diagram for each.
This video was more about the Ipswich test, the using the tips of 1, 3, and 5 toes with your finger. So you don't even have to have a monofilament to kind of just have a gross understanding of the patient's fine motor, fine touch sensation to determine even some possibility of loss of protective sensation. So that's your finger to their foot, and in large swaths of the country, Ipswich is utilized when there is no monofilament in sight. So for my nurses who are in areas where you don't have a monofilament or you don't buy them very often, you can absolutely use the Ipswich test to determine whether where your patient has any possibility of loss of protective sensation. All right, and keep going to the wrong place. You guys still see my screen okay? Are you guys looking at monofilament testing? Let me just stop sharing and share it again, make sure I have the right location. So using monofilaments, and most of the time you can purchase the monofilament in bulk and disposables. So you see this motion that the doctor is using. You're only going to apply the monofilament to the foot one time. You're going to press once, so it's not like a tap. You're pressing and bending that 10 gram monofilament testing strip on the patient's area just so they can feel it. You're not tapping, because if they don't feel it, they don't feel it. You're just pressing. You're pressing and you're letting go. That's it. That's it. So let's go see.
To check sensation on the feet, use a monofilament in various locations.
That's all we're doing. We're bending. That's it. We're not tapping. So my students, if you're tapping, it's wrong. Okay, so that's it. I mean, that's a pretty easy video. Let me go back to the lecture so we can continue.
Assess pupillary production in a darkened room by shining the light toward the left eye.
All right, let's go back to our lecture. Okay. So there are specific areas where you utilize the monofilament. There are 10 spots on each foot. We've got 1, 3, 5 on the tips of the toes, and we have 1, 3, 5 on the metatarsal heads. Oop, there's stuff going on in the chat. Let me see. Okay. And then there's the medial and lateral aspect of the arch, and then the heel is number 9, and then finally between the first and second toes on the dorsal aspect of the foot. Sometimes there are thickened callus areas on those spots where you're pressing and patients cannot feel. I had a student ask me that yesterday, like, what am I supposed to do? Like, they can't feel it because it's so thick there. Is that a negative result or is a positive result? And honestly, it's absent. If they can't feel it, they can't feel it. So it's not, there's no sensation there. So it is we subtract that from the patient's value for their monofilament testing. Okay. Any questions about, we've already gone through inspection, we've looked at vascular, we looked at derm, we've looked at neurological a little bit. We have a couple more things to talk about with neurological, but I want to make sure that everybody understands that there are no questions. Again, you can stop me. I have no problems with that. All right, so finally, we're going to discuss the vibration test. And this is only possible if you have a vibration tuning fork. So if you don't have a tuning fork, then that's fine. The different types of neurological testing assesses different nerve fibers. Monofilament is for that fine touch. The vibratory test is, for a different part of the nerve fibers. So it's just trying to determine like which one is affected. So if you don't have a tuning fork, then just omit this in your neurological testing. But if you do, it's similar to the monofilament test where you ask the patient to close their eyes, and we're going to And we're going to go ahead and smack that tuning fork and lay it on the patient's first, the distal aspect of the foot, and the most common location is at the big toe. And then you ask the patient, number one, do you feel it vibrating? Yes or no? Yes. And then either you remove the tuning fork or you can just press it at the tip to stop the vibration. And then you ask them, let me know when the vibration goes. And then they will tell you that. Okay, so when we're doing the tuning fork, you have to do it on two locations, distally at the foot and then more proximally at the anterior shin. You can utilize the anterior shin, you can utilize the medial mal, or you can utilize the lateral malleolus, just a bone in the more proximal leg to determine whether we have vibratory sensation there. All right, so we're gonna move on to the next aspect. We're gonna go talk about wound care a little bit. So like I said, wound care can be complex. You know, patients can have wounds that just seem just impossible. You know, they've had it for years and you're just like, oh my God, what do I do? I don't know what to do. But okay, first, we look at the patient. We assess the patient. They have to, number one, be as healthy as we can make them, because unhealthy patients are not going to heal. It's going to be tough to get them to heal. So if their nutritional status is not up to snuff, we refer them to nutrition. We get their protein intake up. You know, we draw those labs and we make sure that at least that we can handle. But when we're taking a look at the wound, we have to make sure, number one, is it infected? There's so many wound classifications. There's different types of way to assess. But again, I'm trying to make sure that everyone from my undergrads all the way from my old MD DPMs will be able to have a kind of a rubric in their mind of how to assess these wounds. So we want to know, one, is it infected? That's yes or no. My students and my docs will, can you guys mute, please? Thank you. My students and my docs will look at this this photo on the right and immediately see that we've got a distal phalanx saying hello, and that this is an obvious osteomyelitis or bone infection type situation. But for my non-pods who don't look at wounds all the time, to assess infection, we want to know if it's red. In darker skinned individuals, that can look more of like a dark purplish, maroonish, you know, coloration of the foot. We want to know if it's hot. And you're comparing the heat of that area to the rest of their foot proximately. So as we move away from the area, if the skin temperature is less than the area is hot, then we know that there's something happening here. Is it swollen? And it can be pitting or brawny, just as, you know, kind of basketball kind of appearance to the foot. Is there pus? I mean, if there's pus happening coming from the wound, then it's definitely infection. Our lymphocytes and, you know, antibodies are happening, things are happening to try and combat a bacterial infection if there's pus involved. So 100% there's infection happening if there's pus. I had a question before about drainage. If things are draining, does that mean that it's infection? It doesn't necessarily mean that. Serous drainage or like a clear drainage or a yellow drainage that, you know, has that kind of light tea appearance, that doesn't necessarily mean infection. But pus 100% means that there's some infection going on there. And absolutely, if there is bone exposed, we have an infection. We have a fulminating infection. I mean, there's, you know, again, different types of infections. There's, you know, all the way from a simple infection to cellulitis to gas gangrene, which is an emergency. You know, folks, if your patients have gas gangrene, they really should not be followed in the clinic. It's a hospital thing. It's you know, get them to PMH so that they can get an emergency, incision and debridement. Otherwise, we're going to lose parts of that foot and toe or leg or even their life with gas gangrene. And the idea is to, reduce the numbers of amputations in the Bahamas because 50% of every patient who has an amputation in 5 years, they'll die. They'll die. So to stop or prevent that from happening is to save lives, I mean, if you've talked to my admissions director, Dave, he'll say, oh, how many people think about, podiatrists, saving lives every day? But we do because we prevent, things like these terrible amputations from happening, to keep these limbs on folks so that they don't have this high mortality rate and death in 5 years. So yes, we are podiatrists and we do save lives. All right, so let's make sure, number one, not infected, okay? Number two, we want to talk a little bit about debridement. So when we get that first wound in, we want to check to see, can we remove all of the dead tissue around the foot? So I will typically tell my students that a wound
Don't take me to that
mute, or are we having questions? Any questions? Okay. I will typically tell my students that with debridement, if you have a wound that comes in, what we want it to look like really good healing, is going to be nice and bloody red, like a red steak. That's what, if it's bloody red, then that's what we want. Don't want to see colors like yellows or greens or grays, because that is not going to heal. So that kind of thick fibrous tissue that's on the wounds, we want to make sure we eliminate that. So this is actually a video that I took my very first time coming to the Bahamas with the patient, where we were debriding her bedside. And you can see that I am cutting off.
What is man of time again?
Mom,
What Anisha
how are you?
Oh,
Jovi, can you mute? Thank you. So it looks like we're debriding. We're taking off all that kind of grays, yellow tissues, and underneath we're finding, and I know the video is kind of crazy. I had one of my students doing this, so we're going upside down, but we're trying to remove, all of the tissue. So this is kind of my first layer of removal of the this
I don't know
infected
why my video went away.
Londonio. I can hear you, my love.
Yeah.
And you see also at the more
me can't hear.
can you can't hear the video? No. Hold on. So I can't see what's happening here. There was no sound to the video. That's what you guys were asking me about?
I think it's more a Wi-Fi issue from where we are. So it's just
okay.
being spotty and giving us a tough time, but carry on, sorry.
Okay, I gotcha. All right. Okay, go back to the lecture. Okay. So I would say debridement isn't a skill that I would try unless you have some knowledge of, so, my nurses, if you've never debrided anything before, I would not recommend it. I don't think that you should start, debriding wounds. Yeah, I'm trying to get it down to blood red. This is more of a skill better suited for my docs and definitely better suited for my podiatrist, who knows, the layers to get to, what we need to see post debridement. So if there's a wound that needs to be debrided, if you see a wound and it's yellow, grays, if it's not that bloody red, then they need to be referred to either Dr. Johnson or one of the other local podiatrists so that we can get that removed. Okay. So let's talk a little bit about offloading. Last year, a company called Darko International came and they donated a bunch of these devices over here on the side. This is actually a Pegasus Peg Assist device that can go in a post-op shoe or it can slip right into a patient's sneaker. So you don't have to, have felt or, try and create some type of offloading device to go into the shoe. You can use one of these guys. So Dr. Johnson, you have access to, because they were donated to the Ministry of Health, so you can always go and grab some Pegasists to be placed in the clinics so that, when the patients come in, you can offload them and use them in the shoes so that it is, and this is much simpler than trying to create offloading devices using felt or any other type of material. There are quite a few still left over, even from last year to this year. So use them, make use of them. Darko wants to make sure that they were available to you guys. So use them, absolutely 100%. But again, offloading, the principles of offloading is another one of those skills that unless you have some training, I would not recommend doing because we want to make sure that we float the areas of pressure so that the patient is not walking on it. So there is a little bit of skill needed to offload appropriately. So if you have never offloaded, I would not recommend it. One of these days, we'll have kind of an in-service that, I can teach you, or if you're in any of the clinics that we're in, we can teach you how to use the Pegasus so that you can use it on your patient. And this is to my docs on the call or to my nurses on the call. We can teach you how to use the Pegasus. But again, if you've not used it, I would not recommend it without some training. And finally, let's talk a little bit about some dressing techniques. And I think this is because everyone always asks me, what am I supposed to do with this wound? And it's such a complex question because a wound one day is going to be different, several days, several weeks, several months down the line. So you are always looking at the wound that's in front of you, not doing the same exact dressings that you did, the last time, because it might be a different type of wound. It might be infected now. There might be an element of pressure there. You might have to there might be, some edema that has to be addressed, so there is no absolute when it comes to dressings because that's what's happening. So we've got, if we've got a venous wound, I think, just to be on the safe side, compression. We need some type of compression, and an Una boot is widely available. But again, an Una boot is not something, if you've never put on an Una boot, make sure you have some training because if you don't know how to do it, you can actually cause some issues. So I would just say if we have a nice strong pulse, venous wounds, a compressive type dressing is where we want to go. If we have an arterial wound, and this is honestly for any wound, if there's no blood flow or if there's compromised blood flow, I don't care what you put on it. You can buy the most expensive thing you can find anywhere. It will not heal because without blood, nothing is going to heal. So we have to get those patients to a vascular doc to open up those vessels to get you some blood because if there's no blood flow, nothing's healing. And finally, pressure or diabetic neuropathic ulcers, those are the ones that need to be offloaded. So those are the ones that we're going to need for those Pegasus. So I always have folks ask me, what's the difference between an arterial wound and a venous wound? I will typically say an arterial wound looks like somebody took a cigarette and pressed it against the skin, you know, like this fine demarcations and that dark necrotic look of arterial wounds. That's kind of what it looks like. Venous wounds are very irregular, and they don't look black. You know, they like to you know, get very yellows and pinks, and so, but you know, but arterials are more black necrotic wounds. And this is just a kind of a cartoon of a diabetic pressure ulcer because of the location. You know, you can imagine that the bone under this first toe is pressing down as the patient is walking, and we would need to offload this. So I am almost running out of time here, but we started a little bit late. But I just want to stress the importance of multidisciplinary teamwork. Again, Dr. Londonio is going to talk a little bit about this on Thursday, but use your team. The podiatrists in the area, the vascular doctors in the area, the orthos in the area, physical therapists in the area, the infectious disease specialists, the wound care nurses. Diabetic foot ulcers need everybody in the room. They have to have everybody. I mean, it's a multi-specialty team approach that are going to get these guys to heal. So my medicine team, you know, you're going to need to be there to get their blood sugar under control. My podiatrists are going to need to be there to do all of the kind of expansive wound care. My vascular docs, to get me some blood. My orthos, you know, especially if I have issues from the knee proximal. My physical therapist, who's going to help me post-surgical or post wound care healing. My infectious disease doc are integral because they're going to be the ones who are going to give me my antibiotics to get these patients healed. And my wound care nurse are going to be almost the most important because they're going to be the ones doing the wound care every day. So we're going to really make sure that those wound care nurses are highly trained when it comes to the diabetic patients. And there are some surgical options for diabetic foot infections or diabetic foot wounds, but that is going to be discussed more fully on Friday with Dr. Sai. So finally, we're going to highlight a little bit of communication. So get to know your team in the area. Who's the physical therapist? Who's your orthos? Who's your vascular guys? Who are your podiatrists? Get to know these guys because, you know, effective communication is really what is going to get your patients healed. Okay. Thank you for your attention. Are there any questions, anyone?
Morning, Dr. Hill. How are you?
Good morning, Dr. Johnson.
Once again, thank you for your fine presentation, your great leadership in this arena. Beautiful work. I learned one or two things this morning again. I wanted to say your idea of communication is key. If you could reiterate that with our groups here in the Bahamas. We have a funny country, it's a massive place with funny systems and setups, 700 islands, 100 clinics all over the place. Thank you for the donation of the Pegasus boots. If they could have them sent to South Beach Clinic, where we only have one podiatry clinic, that would help us tremendously. Yeah. Thank you. God
Dr.
bless.
Johnson, you would just need to contact the ministry because it's theirs and it's stored by them. So just have them send them over to you. We have some now that we were allowed to borrow. So absolutely, they are yours. So they're yours.
Thank you. I'll ask Saunders to follow up on that today. Thank you kindly.
Any other questions? So I do hope that you guys learned something today. We ran a little bit over time, but that's okay. If there are any questions, I'm going to put my email in the chat. I'm always available. Gosh, how do I get to the chat? All right. I am always available to answer any questions at any time. If you all are interested, it's just shill@berry.edu. So have a good morning, everyone, and I do wish you all a good day. My students, I'll see you soon.